when we have a patient, we've made the diagnosis and we're thinking about treatment, what are your long-term goals for the patient? You know, we know that this is a chronic disease. And so what are you trying to achieve for the patient, knowing that they're going to probably live with this disease for their lifetime? Dr. Gernsheimer.
So obviously all patients want to be cured.
Yeah.
That's what everybody wants. They want something that is going to allow them to walk away and never see me again. And, you know, my patients say, I really like you, Dr. Gernsheimer, but I'd really rather not see you as often as I have to. I think that the idea of cure is probably not realistic for the majority of patients unless we can find some underlying reason for it. So I think the long-term goals are to minimize, for me, minimize steroids.
Okay.
And I think that's incredibly important. And it's to get people back to living their lives normally and for their treatments to affect their life as little as possible. I'm looking for a safe platelet count, not a normal platelet count. And I think patients sometimes have trouble with that idea. I'll tell them, oh, well, you know, you're up to 80,000. I'm so pleased. And they'll say, but it's still in the red. It's
right.
still
it's not normal.
Red. They don't like that.
Yeah.
But I think over time, people begin to understand that really the goal is to keep them safe.
How about you, Dr. McCrae?
I agree with that. I tell patients, you know, you're probably going to have this disease for a long time. I suppose I'm a little more idealistic and still have this hope that I can make their ITP go away. And so I am I don't know what the correct approach is, and there's conflicting data and emerging data on early treatment, but I am a proponent, I think, of aggressive treatment early in the course of the disease with more than just the standard of care, probably, although some of that is out of my hands. It's in the hand of the insurers because these approaches are not inexpensive.
Yeah.
But in general, I do agree with what Dr. Gernsheimer said. I mean, you tell patients this is probably a long-term disease. I tell them with the right patient, there may be some things we could do for you up front if the conditions are right and you're willing to take a little more medication-induced discomfort.
I'm glad you mentioned more aggressive upfront therapy, and we will get to that because I'm very interested to hear what you have to say. I want to ask, I'm just curious, in your experience, how do patients present with this disease? Is it that patients present with symptomatic bleeding, or is it just the laboratory value on a CBC?
You know, I think it depends on your practice to some extent. You know, we certainly get a lot of asymptomatic thrombocytopenias that are discovered incidentally on the annual physical exam and annual blood count. On the other hand, in my practice, I get patients, probably the most common source is people who have been hospitalized for initial course of ITP or have failed, you know, early treatments. But so the patients who are initially hospitalized are often asymptomatic. Symptomatic at the time. Maybe not with frank, life-threatening bleeding, but certainly with bruising and perhaps, you know, epistaxis or things like that. I think that you know, we all have different thresholds for admissions, and you know, when you come to an emergency room with a certain level of platelet count, you're probably going to get admitted, which a hematologist might not admit for that.
Sure.
But
so
I would say I probably get about 50-50 of those different types of patients that I see.